individualizing care, individualizing any patient's regimen, starts with what? How do you identify who needs this? How do you identify how urgent this is? Is it the HIV RNA level, the CD4 count, what? How do you go about starting?
Well, I think it's my job as a clinician, as a doctor, to look at the patient, to look at their entire medical history. Do they have comorbidities? Are they going to be taking other medications that may have some side effects and or drug-drug interactions with the potential HIV medicines that I'm going to choose? How likely are they to take their medicine? And we as physicians as a whole are not always the best at predicting that, but yet we still have to do that.
We're not even the best at doing that. There's that famous study, right, where they gave a cohort of medical students one placebo per day and said, just take it for a year. And at the end of the year, they counted the number of pills that weren't taken. It was about a third. So we're not very good at predicting adherence, are we?
But we still have to do that, and there are some signs or some suggestions that somebody may have some issues, depending upon. Oh
no, I was just going to say. Sorry to interrupt. I was going to say, there are a lot of people working on more of the prospective analytics and patient segmentation, and a lot of it's because we have better IT, we have better outreach programs to patients. So I think we are kind of trying to look at that a little bit differently, trying to figure out what's going on with that patient, what type of patient they are, so that we can frame our interactions with them so it's more effective. So one person may prefer a person-to-person, another may prefer a text. Just understanding how they're going to respond to things, I think, is huge.
And then you've got to, do you need to identify the virus de novo? In other words, in terms of its resistance or non-resistance, do some people get infected right away with resistant virus?
It can happen, and it's still important to do, if you will, a fingerprint or a resistance test on all people coming into care. The question is, do you need to wait until you get the result before you start people on medicine? And the trend now is moving towards testing and treating immediately starting somebody on treatment, because of the concern that if you wait, if you have them come back in a month to go over the results of their baseline testing, there is always going to be a certain number of people who don't show up.
A month? Is that the turnaround on these tests? Is it a month?
It depends which program you work in, but sometimes it can be 2 to 4 weeks to get back a turnaround time. But even if you say it's 2 weeks, you still run the risk of losing people, of somebody not following up, not coming back, and losing them to care. And if the idea is, at the end of the day, to get as many people on drug, completely virologically suppressed, so that we reduce transmission, recent data suggests that if we test and treat immediately, we're more successful at getting more people at that goal.
Now, if you were to test and treat immediately, and you wanted to be sure you covered the waterfront, you would treat everybody with a drug that was least likely to induce viral resistance, and then go backward from there and downregulate those people who have virus that's not subject to that. But that's not what happens, I'm guessing.
Well, actually, if you look at the recommended regimens for test and treat protocols, they, for the most part, encompass that.
Really?
Yes.
There's common sense out there?
There is common sense, and actually I've been asked by the state of Florida, when we designed our protocols for test and treat, to weigh in on that, to say, well, what regimens do we think would be most likely to cover either the rare case of transmitted resistant virus, or on the flip side, to be more resilient to the development of resistance should somebody be prone to missed doses in the very beginning.
Okay, does that make sense to you? They're going to give a more expensive, I'm assuming that that's more expensive.
I don't know what the cost of that product or that regimen is, but I'm assuming you're talking about darunavir and...
Darunavir, dolutegravir were the two main choices that we
Yeah,
have gone
so
with.
from our perspective, again, because we want to end the epidemic and we want individuals to be virally suppressed, and so if there's a drug that's going to, that has a high barrier to resistance, and if you miss 1 or 2 doses here or there, which I'm not advocating at all, but to have,
Duly noted.
Yes, but it won't affect any resistance issues, then we would be supportive of that.
That makes sense to you?
I would agree with that. We'll be supportive of that. There's still other reasons for somebody being non-adherent. So I don't want to look at this as a Band-Aid, but I agree, you want to start with the drug that has the best profile.
Okay.
But you still have to do other things to help these patients along.
So you start with the big
Yeah.
gun and then move back if you can. Is that fair?
So I don't think you necessarily move back. I think you keep that big gun in place.
But is that
if
the
that
new
regimen
is
is
that-
working
is
for
that-
them.
Are those
So
the
it's
new
not-
guidelines?
Yeah,
So
well, we don't change. I agree.
Yeah, so it's not like antibiotic resistance or anything
Right.
like that.
So I think that the recommended regimens that we've just reviewed, the recommended for most patients and recommended in specific or certain scenarios, I think once somebody starts on those regimens and they're successful, we leave them on them. There's no compelling reason to switch them off.
But is that in keeping with the latest guidelines? Because my sense of the guidelines is the people who get the powerful resistance drugs are the carve-outs. They're not the run-of-the-mill patient. Am I wrong about that?
So the one
What am I
product,
missing?
the one product that you mentioned was dolutegravir. So that is an integrase inhibitor. So that's actually in the guideline as a
Okay.
first-line treatment. And the second product you mentioned was darunavir, which would be in the other or the certain population category. So I think actually what you're talking about is actually in the guidelines.
They're both